Friends, I have been given a very important topic to discuss with you, that is Candida auris. This is the first time we are seeing one fungus inside the bacterium, or a fungus which is behaving like a bacterium. Why I have said this? Because it is developing resistance very fast, which is not a character of fungus. It is easily transmitted already in 43 countries, and it is causing high mortality. 30-day mortality is nearly 67%. And this mortality compared to all other Candida species is much higher, and causing increased hospital stay around 68 days, and in some center it had even up to 140 days. This particular pathogen is resilient. It survives disinfectant, desiccation, high salt. It contaminates the environment very fast and not easily identified, causing multiple outbreaks. So all things are bad for this fungus in case of humanity. But only good thing is that scientists and researchers are taking special interest. That's why you can see so many papers have been published around Candida auris in this. So friends, the story started in 2008 in Japan. From the ear of a patient, this fungus had been isolated. And within 2013, 5 countries which have been there. And when we have looked into recently, we found that this particular fungus had been in 43 countries. And 16 of the 43 countries are in the Asian region. But when people tried to look into their culture collection, they found that they could go up to earliest is 1996 in South Korea. Amongst these culture isolates, they could find Candida auris. Similarly in Japan in 1997. But friends, until unless it reached USA, people didn't pay attention. So in New York Times, in the front page, when it had been highlighted by Tom Chiller, that had really helped. And first time, Candida auris, one fungus, has been included in the urgent threat category of this CDC-nominated fungal disease. So in our country also, Indian Council of Medical Research first time issued an advisory in case of Candida auris. But friends, we lost sight of Candida auris in COVID-19. Rather, COVID-19 overshadows every other disease. But Candida auris didn't remain silent. Already it had come up, whether it is in Mexico or in case of the Florida, or even in case of the India, we are finding Candida auris incidence are increasing. To a great extent, it is because there are lapses in infection control practice during COVID management of the patient. Healthcare workers are extending use of PPE, and there is also lapses in adherence to the hand hygiene. These are all important factors. Now, when you ask me what is the magnitude of the problem of Candida auris, I would say this is the only important study in our country which we have done way back in 2011 and 12, where it has shown that out of 1,400 Candemia cases, Candida auris was 5.2%. But when we have looked into the last year, this particular paper, in one center, Candida auris is the first rank in order. In South Africa, you see this is the 4th rank in order. And in case of private sector hospital, it is 2nd rank in order. In Spain, pre-April 2016, Candida auris hardly had been isolated. But after 2016, you see Candida auris is the major important factor. Now, in case of Candida auris, whole genome sequencing has really revealed a lot of important facts. First important fact is that there are 4 clades, and these clades are quite well separated. And inside the clade, all the strains are almost similar. Possibly there is a 5th clade is there, which have been shown in case of Iran. But there are mixed clades in case of UK and US. And if you look into these clades, there are a lot of difference in case of susceptibility to antifungal. South Asian clade, that is having very high resistance to fluconazole and amphotericin B, and nearly 50% of them are multi-drug resistant. On the contrary, the East Asian clade is very low drug resistance, only around 10% fluconazole resistance which have been there. And if you look into the clade 3, there is high drug resistance to fluconazole and voriconazole, but not against amphotericin B. And clade 4 in South America, it is variable drug resistance. In Venezuela, even up to 50% resistance to amphotericin B. So friends, how this drug resistance has increased? Look into this data. This shows very clearly 2009 to 2016. You can see fluconazole resistance MIC, which was 2, had gone up to 64 or more than that. And since 2016, we are seeing almost every strain is fluconazole resistant. Voriconazole resistance and posaconazole is increasing, but most worry is this data, which yet we have to publish, which showed that drug of choice is echinocandin, but even in case of the echinocandin, the resistance is increasing. Nearly 20% resistance has been seen. Now the question is why such quickly the antifungal resistance is developed. There are several studies comparing in the non-auris Candida versus Candida auris. And here it has shown in case of the azole resistance, there is higher ABC efflux pump, and even there is CDR pump, which is very important. And they found there is the mutation in transcripting factor TAC1B, that is very important. There is segmental duplication of chromosome 1 or chromosome 5, which have been associated with azole resistance. In case of echinocandin resistance, it is the FKS1 is important, and 3 mutations had been found. In pollen, there are, in general, we don't know what is the mechanism of pollen resistance, but here we have seen 5 SNPs. And we have found that those strains which have got this mutation in ERG3 or ERG11, that is low susceptible. And 5-fluorocytosine, of course, the standard mutation which have been there. So if I have to show in cartoon, azole resistance, the efflux pump is important, HSP90 is important, and TAC1B is also important. In case of echinocandin resistance, it is the FKS1, 3 mutations which I've shown. Pollen, we still don't know very clearly, but possibly certain things which there is shown that 5 mutation and possibly ERG3 and ERG11, which are also important. Friends, a new things which had come very recently. It had shown that 2 protein signal transactional pathway is very important. One is the SSK1 encoding regulator protein, and another is that is HOG1. When these 2 have been removed, the strains can be made susceptible. And they found that loss of these alters the membrane lipid permeability and mannan content. So these are the way people trying to understand why the resistance is emerging so fast. But I would say we have not the final answer why it is behaving like bacteria. Is it that some transposon? Is it that something lateral gene transfer which are important, which we have no answer yet? But in case of Candida auris, we have seen also biofilm may be an important factor for resistance. In case of Candida auris, we have got 2 types of strain. One is the aggregated strain, another is the non-aggregative strain. Aggregative strain is seen more in the environment and in colonization type, and non-aggregative type is more touchy. And when it looked into the biofilm, this is 2 studies, this is our study, we have shown there is variable biofilm formation. We cannot say very much, but one thing is that aggregative strains possibly produce more biofilm which is being there. So coming to this biology of Candida auris, besides this aggressive, non-aggressive type producing biofilm, what it had been also looked into the pathogenesis of druids. This has been looked into in case of Galleria, where it had shown that the non-aggregative type is more virulent than the aggregative type. Candida auris is haploid. It has got 7 chromosomes. This is the genome size, and more than 5,000 predictive genes have been found. Though we don't find any sexual reproduction in case of Candida auris, but possibly there is a chance of having sexual reproduction because both the types are available. We have also seen there is some phenotypic switching, especially with the temperature, which can be seen in case of Candida auris. But very recent data has shown even Candida auris can have diploid form. This can be developed in case of in vitro, in YPD medium. It can grow within 7 days, or again diploid to haploid by making another pre-pro medium which is having yeast extract peptone glucose agar at 25 degrees centigrade. And what it had been shown in case of the animal, that diploid cell though grows slowly but more pathogenic. You can see these are the diploid cells which are more pathogenic compared to the haploid cells. Coming next to another question, where from Candida auris has arrived? A lot of people said that possibly our improvement in diagnostics has now helping Candida auris was existing long back. But when the century isolates, it's a large collection of isolates, it had been looked into, only 6 had been found to be of Candida auris. So you cannot say misidentified factor. Antifungal selection pressure, is it so important that this Candida auris multi-drug resistance has emerged? But the hotspot of Candida auris do not coincide with the azole overuse area or even agricultural use. Some people say human migration. Yes, human migration can justify multiple clades in UK and USA, but it cannot justify what is the origin of Candida auris. But this group, Casserable and workers, they propose that global warming and migration is important. So they have made a very good cartoon. And they tried to say is that it was present in the wetland, and by the birds it had gone into the rural environment, and after developing in the rural environment, it had come to urban environment. But friends, we have never isolated Candida auris from avian host, and we have not seen any evidence of rural multiplication, and we have not seen rural to urban transmission. So friends, this is our hypothesis. We have published in the same journal. What we try to say is that Candida auris is existing long back. You know, Earth was the 2 mass. One of the mass was Gondwana mass, and possibly Candida auris was there. And after the major fall, lineaments, which separates out this particular Gondwana into different regions, Candida auris also had separated that time. And this particular theory is supported by our recent paper on case of centromeres. In centromeres, what we have seen is that there is conserved centromere in case of Candida auris and related species which have been there. You see, this is small regional area which is very much conserved in that. And here, this particular conserved region, because of some inactivation event, led to karyotypic alteration. That's why we are seeing some of the clades and evolutionary trajectory to the unique karyotype associated with clade. But friends, this must be happening in the environment. How human acquire these from the environment? Let's go to the molecular clock, which have been studied in case of Candida auris. It has shown clade 1 is 140 years back, clade 2 339 years back, clade 3 175 years back, and clade 4 is more recent. Now, what we have found that there is certain important incident which happened during that time. Like suppose clade 1, it is in 140 years back, there were 3 famines which were there. And the relief came from UK and Saudi Arabia in case of the India and Pakistan. And here, both in UK and Saudi Arabia also, we found clade 1. In case of the clade 2, this was the oldest one. Here, there is in 1677, earthquake happened in case of Japan and simultaneously also in South Korea. And this tsunami possibly brought Candida auris from the environment to the human being. In case of the clade 3, it is the massive human migration happened, Great Trek, which has been called simultaneously. And in case of the clade 4, what we believe is that in case of Venezuela, there was the oil crisis. People were digging everywhere for looking for the oil. And because of that, they possibly has acquired. I know this is a far-fetched theory, but we need to look into this aspect. But then once they have acquired it, how they had come this particular disease now? Possibly it remains a sleeth existence. Now this sleeth existence changed with the antifungal antibiotic consumption. Look into, I know this is a bit busy, you can see the countries where it is the clades which have been primarily seen. In all this country, antibiotic consumption, antifungal consumption, even acute and chronic care-wise, bed number-wise, there is a good correlation which have been found regarding the association and timing on which they appear. But that had not been there where there is no Candida auris, which have been, it had developed in case of human migration in this country, so it was not associated like that. So friends, what we have collected the information wise, there are environment, host and pathogen all possibly driving this emergence. Environment driving because of the antibiotic antifungal, and in case of the host, what is driving is that critically ill patient where there is more catheterization, broad spectrum antibiotics, they are acquiring this infection. And this particular fungus, already I have said, it is a resilient fungus. It tolerates disinfectant, temperature, desiccation, and robust biofilm. Now, with this, some of the concept, let's come to the clinical area, which is the challenge, how to handle this particular fungus. Where we do see this fungus? Most commonly, it is seen in case of blood, then in case of urine, it can be seen in wound, lung, and other infection. And risk factor-wise, it had been found that the renal impairment, cardiothoracic unit or ICU stay longer period of time, mechanical ventilation, central venous catheter, total parenteral nutrition, sepsis, and antifungal drug use are important risk factors. In India, when we looked into those 27 center study, we found that prior antifungal exposure, almost similar, underlying respiratory illness, vascular surgery, multiple interventions, which are the important risk factors. Now, I told you that Candida auris diagnosis or identification is difficult because commercial phenotypic system is not helping much. Possibly the updated version of 8.01 in Vitec claims the identification by phenotypic method, but it needs further evaluation. So to identify it, we need this MALDI or sequencing. Now, we developed this media very recently published in 2021. We found that in YPD agar, along with high sodium chloride with ferrous sulfate, if it is incubated at 42, it selectively grow Candida auris. And within 72 hours, 100% of the isolate can be identified. People tried with different types of homogenic media, and this homogenic media showed that these particular isolates are different from the rest others. But friends, this is a little bit difficult to really compare and differentiate from others. Now, whenever this Candida auris has come to the hospital, how to prevent, or how to prevent its entry inside the hospital? You know, this is a study which we have published in case of Journal of Hospital Infection. In trauma ICU, there was a patient who came here. This is the trauma ICU picture. And we found that within 4 days, all the patient gets colonized. So here, the contact transmission is very important issue, and possibly environmental contamination is important. Rather, Candida auris persist anywhere and everywhere. It can colonize axilla and groin. It can persist on the thermal reading which has been taken there. It has been found to be contaminated. It is isolated from furniture, catheter, reusable equipment, infusion pump. So everywhere it is being present. But it is not only axilla and groin. Very recent study had shown, like Staphylococcus aureus, it can persist in the nares as well. That is very important, which was not being seen earlier. But very recent data, in case of by doing the metagenomics, what they have found that not only axilla, nares, and also the groin, even it can be present in toe apes or inguinal crease, or in case of fingertips. These are the other sites where it can persist. So we need a periodic point surveillance or prevalence survey in high-risk facility to know whether there is Candida auris. But here again, you will tell me, if we have to do an early detection, say suppose in your hospital, there are referral patient comes from another hospital and goes straight to the ICU. Can you screen that patient whether the patient is having Candida auris before entering in the ICU? We know that chrome agar can possibly help. It has got a different color which is there, but it takes 24 to 48 hours. So where will we keep this particular patient? But I would say that very recently, this particular company had developed one of the kit which claims that they can identify if we have in the axilla, groin, or near Candida auris within 1 to 1.5 hours. So to control Candida auris, it is the hand hygiene. Contact transmission blockage is the most important factor which we have to do. And here the colonization, as I mentioned, is the axilla, groin, or in the nears where it has been, that needs to be looked into. If there is a colonized patient, we need to do a bathing of this patient with chlorhexidine. And this also very difficult. Some of the patient takes more than 3 months to get out of it. CDC has recommended the standard contact precaution training. They said that the patient should be put into a separate room in those cases, but it is not possible in majority of the Asian countries. But what we can do is that we can improve hand hygiene. We can improve the cleaning and disinfection. These are the other factors which can be improved. Now, when you should think you are dealing with Candida auris in your lab or any of the patient who is coming in the hospital, first thing, if the patient is in ICU or high dependency area, transfer from another hospital after a long stay. That's very important issue. Multiple intervention prior antifungal exposure. If your commercial system is identifying something rare yeast, think about can it be Candida auris. And if it is resistant to fluconazole and voriconazole, then think about Candida auris. I would say that any is growing at higher temperature and azole resistant, think about Candida auris. In therapeutic option, because of its resistance to fluconazole and to a great extent voriconazole, even amphotericin B, echinocandin is the drug of choice. But again, I am trying to tell you is that our Indian data showed already resistance to echinocandin is increasing. So can we use posaconazole or isavuconazole? More data is required. New drugs have been found which can be also active against Candida auris. So friends, at the end, what is the key message of my presentation? First thing is that Candida auris is a red alert in critically ill because mortality is more than 50%. Predisposing risk factor is prolonged hospitalization, previous antifungal exposure, immunosuppression, invasive procedure, and mechanical ventilation. Erroneously identified phenotypic yeast. Think about those areas. Can it be Candida auris? And it requires sequencing and MALDI-TOF for confirmation. Our new selective media, which have been proposed, can be used and looked into. And I said that in case of the admission screening, there is now a kit which has come up, which is a PCR kit that possibly can pick up within 1 to 1.5 hours. This particular fungus is uniformly resistant to fluconazole, already high MIC to voriconazole and amphotericin B. So echinocandin is recommended, but use it carefully because echinocandin resistance is emerging. For environmental or medical equipment, effective terminal cleaning is very important to get rid of it. But I would say several unanswered questions still remain. We have tried to look into the origin. We have given a lot of hypotheses, but still I would say all those hypotheses need to be proven. We need to still see why there is rapid antifungal resistance. We need to look into how to control and also what should be the therapy in case of multi-drug resistant bug. At the end, I'd like to invite you for this World Congress, which is going to be held next year in September 2022. This is the 21st Congress of International Society of Human and Animal Mycology. It would be in Delhi. I welcome you all to come to that particular conference. Thank you for your kind attention.
Hi, Prof. Given that the propensity for this Candida auris to be multi-drug resistant, in the face of a critically ill patient in the intensive care unit, do you think there's a role for combination and antifungal therapy in this case?
Thank you, Dr. Shuwei, for inviting me in this conference. I would say that it's a bit difficult to say or recommend because there is not very clear data. But when we have seen that our patients are coming resistant in case of the even echinocandin, we had tried in case of the combination therapy in some of the patients desperately. Because, you know, there is the problem is until unless you are very sure that which drug to work, So susceptibility data would be very important. And several times we have seen that they are resistant to fluconazole, voriconazole, amphotericin B, even one or two echinocandin. In such situation, we generally try to raise the echinocandin dose, that is one way, and try to combine with 5-fluorocytosine in some of the patients. I would not say that we are very much successful. 50% of the patient at least we could salvage. Thank you.
Okay, thank you very much, Professor Chakrabarthi.